Welcome to the first 2020 Focus on Aging Federal Partners webinar series. This series is a collaboration among ACL, CDC, HRSA, and NIA. Please note that this webinar will be recorded for future viewing. You will receive an email in a few days with a link to the webinar, as well as some links to some additional resource materials. Next slide. If you have questions, please submit the questions via the live feedback form at the bottom of the videocast page. It can be found at the bottom of the videocast page and click the live feedback link, which will appear as shown to submit questions. We will do our best to answer as many questions as time allows. We have a great group of presenters today. First, Aaron Long from ACL will set the stage, followed by Dr. Samir Sinha from Sinai Health, who will highlight recent efforts from the Red Cross. Margie Sanders from Northeast Ohio Medical University will talk about preparedness from a nursing home perspective. Jeff Klein from Nevada Senior Services will highlight response activities as an HCBS provider. Dr. Kathy Heyer from the University of South Florida will discuss recovery. Dr. Nia Reed from CDC will present information on COVID-19 as relevant to older adults. I will turn it over to my colleague, Aaron Long from ACL.
Sorry about that. Good morning. I am going to spend a couple minutes just laying a little bit of groundwork on the issue that we're addressing in today's webinar before we hear from our experts. So in this slide, we're talking about that emergencies and disasters come in many forms with different causes. There's basically two buckets in which emergencies/disasters can be placed. A human disaster or a natural disaster. Natural disasters are adverse events resulting from natural processes on the earth. Examples include, but certainly are not limited to, hurricanes, floods, earthquakes, and a broad variety of other natural causes of disasters. Human instigated disasters are the consequence of technological or human hazards. Examples include our current pandemic, fires, industrial accidents, etc. There are regions of the country that are more prone to experience natural disasters. Examples would be Florida and hurricanes, Houston, Texas with floods, fires in California. Over time, they've developed practices and resources to address those times. We are quite certain that the present nationwide emergency that we're working through will result in extensive learnings on how to prepare, respond, and recover to emergencies of this magnitude. Next slide. As laid out in the table in this slide, there's many considerations for older adults in emergency situations. Evacuation concerns, people that are caregivers or have caregivers. There could be concerns about separating from caregivers. Lack of transportation. Are people able to evacuate independently? Do they still drive? Do they have mobility issues? Are they able to get out of their residence? Sometimes people can't bring their pets, and that's a very troubling situation. Also, people worry that if they evacuate from their home, their families won't be able to find them, and they have concerns about personal property and their personal safety. Access is always a concern as well. Do people have access to money during an emergency, have money and food, medical information? If they have to evacuate, do they have enough medications? Is the treatment available that they might need? Do they have all the medical equipment that they need? Do they require, if they have to evacuate, will they have assistance with their activities of daily living? If they can't evacuate, will there be gas? Are there utilities available, electricity, gas, and water? And do they have access, if they're not in their homes, to their legal documents? Another concern for older adults is the management of their chronic diseases. Would they have to interrupt their disease management? How would mild cognitive impairment impact that? Alzheimer's and related dementias with an emergency situation is a serious concern, as well as heart disease, blood pressure, having access to all the treatments that they need, and communications challenges are also quite significant. There's a likelihood that there could be some interruptions in communication. Is there phone service? These days we are worried about loss of our internet. A serious concern in communication of late is isolation and loneliness. Next slide, please. So during the remainder of the webinar, we're going to hear from numerous perspectives, experts on preparedness, response, and recovery. And I just wanted to sort of lay the expectations in what we're talking about when we talk about preparedness. That's planning for emergencies before they happen. Being prepared in advance allows for rapid identification, evaluation, and response to emergency situations. Response is an organized response to an unexpected or dangerous situation designed to lessen the impact of the event on people, communities, and the environment. And recovery are actions taken after an emergency that are designed to aid in returning to normal or an even safer environment. Recovery activities take place after the emergency has ended, I guess. So the following behind me are some presentations that are going to put all these things into perspective for you. And now I'm going to turn the webinar over to Dr. Samir Sinha to discuss his slides. Next slide, thanks.
Thank you very much, and hopefully everybody can hear me okay. So my name is Dr. Samir Sinha, and I'm the Director of Geriatrics at Sinai Health and the University Health Network in Toronto, Canada. But I also have the honor of being the first geriatrician to be a member of the American Red Cross Scientific Advisory Council. And I also have a joint faculty appointment at Johns Hopkins, where I finished my geriatrics training. And so at the American Red Cross, a lot of work is being done to help advance, training around first aid, cardiac resuscitation. But part of our work is around disaster preparedness and disaster health. And so as a member of the Scientific Advisory Council, some of the work that I've been doing as part of the Disaster Health and Preparedness Council is thinking about older adults and older Americans and how we could better support them in optimizing emergency and disaster preparedness and responses. So we'll go to the next slide. So the objectives really for this presentation are really to understand how and why older adults are disproportionately negatively affected by natural disasters, identify some key domains around which to consider emergency and disaster preparedness responses, but also describe some key strategies to promote better older adults, to better support older adults to prepare and respond to disasters. We'll go to the next slide. And then the next one. Okay, so to set the context here, older adults experience more casualties after a natural disaster compared to other age groups experiencing similar events. Clear take-home message. We'll go to the next slide. And the next one. So when we're setting the context here, we can see from the graph that you'll just see here that in 2005, Hurricane Katrina basically saw that 49% of the casualties that actually occurred were in people who were 75 or older, 75 years or older. And many of these victims died in their own homes, while persons were actually found in nursing homes abandoned by their caregivers, a real tragedy. We'll go to the next slide. When we think about Hurricane Sandy a little bit more recently, we know that, again, almost half of those who actually died in the storm were 65 and older. And in this case, many of these older adults in a colder climate were found to die from storm-related injuries, hypothermia, and other causes. We'll go to the next slide. And when we actually saw some progress after Sandy in particular, their Centers for Medicare and Medicaid Services established a national set of emergency preparedness rules for all providers and suppliers. And so the rules govern the following domains: risk assessment and emergency planning, policies and procedures, communication plans, and training and testing. And the key thing was this would involve, for example, hospitals. This would involve nursing homes that fall under CMMS, but this wouldn't actually apply to assisted living facilities. We'll go to the next slide. The challenge was is that even after those emergency rules or those rules came into effect, we had Hurricane Irma, we had Hurricane Harvey, and again, this really shows that we still continue to see challenges, such as what happened in Irma, where 14 residents of a nursing home died due to heat-related issues when they were left without electricity to power their air conditioning systems. And so as a result, the state of Florida is the only state now that actually has enacted emergency rules to cover environmental control for nursing homes. No other state actually has these rules. Hurricane Harvey, as we saw, it was actually an assisted living facility, so not a CMMS organized federally funded nursing home, if you will. And so this case highlighted an existing gap in the lack of uniform emergency preparedness regulations for vulnerable older adults in these settings. We'll go to the next slide. So we'll go to the next slide. So really, the key is that persistent poor outcomes highlight persistent gaps in disaster preparedness planning and procedures for older adults. And with the American Red Cross being one of the largest organizations helping, that's a non-governmental agency to help, this was something that we were noticing, and therefore, as a scientific advisory council, decided to do some further work to support improvement in this area. We'll next go to the next slide. So why does disaster preparedness for older adults matter? So we know that, again, the disproportionate number of older adults are affected. We know that the American population is aging like all other nations around the world. And there's going to be an increased demand for emergency response services provided to healthcare professionals and emergency responders. And there'll be an increased need for age-friendly and sensitive procedures at an organizational and government level. And we expect that there's going to be an increase in the amount and severity and frequency of natural disasters. And the costs of these are huge. You can just see the costs alone related to all the various hurricanes we've listed at the bottom. Go to the next slide. So what makes older adults particularly vulnerable in the context of disasters? Because some people say, is it just a matter of age? We'll go to the next slide. So really, this is a little chart we did when we did a scoping review, just to try and understand the issues a bit better. And I won't go through all these in detail, but you can see when we think about older adults, they tend to be living with more chronic health conditions. They may be living with more physical impairments that limit their mobility, sensory impairments that may affect their ability to actually respond as well. There's a greater rate of dementia that we see as we age. There's also other issues such as psychological and social factors, issues related to the social determinants of health, if you can even afford to prepare yourself. And then we also have to think about family and caregiver considerations as well. We'll go to the next slide. And the next slide. And so when we actually look at a framework to actually, how do we analyze this? This is actually an ecological framework that we actually use to underpin the work that we do. Because again, our Scientific Advisory Council, we really try and do rigorous research and analysis. And we did this in partnership with the American Academy of Nursing. And really what we took a look at is we took a look at these issues, but we looked at the framework of older adults and caregivers, at the framework of healthcare professionals, organizations, community programs, and agencies, and also the level of government and policy and how we could further influence that. We'll go to the next slide. So really, this is the question we ask. I want to show you the science behind our recommendations. So really, this is what we call a PICO question, which is basically, this is the big question we asked. What evidence exists for older adults 65 plus in any jurisdiction of any intervention or action for them or for them and or by them compared to adults under 65 to prevent, respond, or recover from a natural man-made disaster? And then we'll go to the next piece here. And so really, when you look at seniors preparedness, This was basically what we did. We did a whole search of looking at various databases. We looked at media articles. We looked at anything we could find, and you'll see that from scholarly articles, we found 993. We identified 56, so not a huge number that actually really talked about that big overall question. And we also looked at 35 other sources, such as, or 35 sources in particular, like discussion papers, book chapters, anything that we could find that related to this topic. We'll go to the next slide. Then we actually graded all the information. So we actually took a look at all these and we said, is this evidence really strong evidence or is it a bit of weak evidence there? We'll go to the next slide. And really, we'll go to the next slide. And really, we then actually took the evidence that we found because you'll see that we didn't have a lot of resources to go by. So the literature really gave us some ideas, but what we wanted to do is we wanted to get an expert lens further. So in addition to our scientific advisory council that has 50 scientists and clinicians like myself, we also actually held a policy roundtable in Washington, D.C. We'll go to the next slide. And we had, and really the rationale to do this was we wanted to actually look at the data around these different groups, and we really wanted to develop, get expert input so that we could actually come up with evidence-informed a policy white paper as well. We'll go to the next slide. And so these are just some of the organizations that were able to participate in that day, and you'll see some of the organizations that are sponsoring this webinar as well. And again, this is an opportunity for us just to have a closed door discussion where we can openly talk about things and come up with some clear recommendations. We'll go forward. Was just a picture just showing you the folks who met that day after a long, busy day of chats. We'll go to the next slide. And these were the things. We came up with 25 evidence-based recommendations. And you can see here, we came up with recommendations specifically around these domains. Go to the next slide. And you can read all about them in our Closing the Gaps report that was actually just released in January 2020. And I think after this webinar, we'll make sure that people get a link so they can get a copy of this report. You can Google it, but you can see all of the input and information here. We'll go to the next slide. And so finally, I just want to say, what can we do? What are some clear take-home messages that I want to summarize from what we found? Go to the next slide. Things that we can do is, number one, we can just raise the topic of disaster emergency preparedness with older adults and their caregivers. And these are some of the other ideas here. Advanced care planning should incorporate emergency disaster preparedness. We want to recognize older adults' preferences and limitations. What are the types of disasters that could occur in their area? And if an older person is power dependent, make sure that they have backup power sources. And if there are vulnerable person registries, are these things that they can rely on? Get people involved and make sure that people have a 30-day med supply and materials ready to stay or go. And so right now we're working on materials that have been funded by FEMA so that we can actually have these in the hands of older Americans and their caregivers. And we'll be launching those by the end of June. We'll go to the next slide. And the next slide. So other things that we can do are making sure that we want to think about things that our colleagues and our affiliated care organizations can do. So again, thinking about, can your colleagues benefit from additional training in the care to support older adults? Do all organizations have clear preparedness disaster plans and procedures? Are local government agencies able to easily leverage data sources to identify at-risk individuals? Are local shelters able to accommodate people with different physical and cognitive abilities? And information for handoffs is really important, especially when transferring people at the time of disasters as well. So we'll go to the next slide. And the next slide. And so I just want to say thank you. And again, if you want to get more into the details, you can find those in our policy report, but I thank everyone for their attention.
Good afternoon.
And we'll pass it to Mark Sanders.
Good afternoon. First of all, I'd like to start with acknowledging Barb Palmisano, Dr. Terry Albanese, and Dr. Margot Ermey, who were instrumental in helping with the guide that I will be walking through with you. And I'm really just going to focus on one method of preparedness as as a guide for what might be useful. Next slide, please. The recent events surrounding COVID-19 have greatly expanded the need for emergency preparedness and response training for really all healthcare and residential facilities. Being proactive in preparing for emergencies, whether they're biological, accidental, or natural disasters, is critical for saving the lives of some of our most vulnerable citizens. Lessons learned from the devastation of Hurricane Katrina in 2005 reinforce the importance of preparedness and timely response. Long-term care facilities have unique needs and must be especially diligent in preparing for disasters and protecting their susceptible, dependent residents. There is no uniform one-size-fits-all when it comes to preparing for emergencies. Plans must vary in accordance with geographic locations, local community resources, potential hazards, and specific institutional response capabilities. Administrators of long-term care facilities should consider their plans in partnership with local emergency management authorities and health departments. Next slide, please. Most facilities have protocols that address infectious disease management in place, as well as disaster protocols in response to things like fires, temporary power outages, tornadoes, and other natural disasters. However, in this new era, current disaster protocols must be expanded to include the possibilities of exposure to new viruses and antibiotic-resistant bacteria. Issues of quarantine, evacuation, vaccination, and treatment of frail elders are of great concern. Next slide, please. So what I'm going to talk about is tabletop exercises, which may be defined as emergency preparedness training activities, which take place in a classroom environment during which personnel are presented with simulated events to work through the response actions. TTEs, tabletop exercises, use a guided discussion format to provide training, development, and team building. They differ from an exercise in which the players actually respond to a simulated event. A TTE is a method of training focuses on both individual and team performance. The objective of a tabletop exercise is to provide cost-effective training with minimal interference to the program operations while meeting the needs of respective facilities. Goals of training in long-term care facilities really are to do a number of things. Ready the facility, particularly in regards to their policies and resources, to meet those challenges that may occur. Response of the staff to ensure the health and safety of their residents, their families, and visitors and staff. And finally, communication strategies to ensure an adequate flow of information at all levels within the facility and externally within the community. So using tabletop exercises, staff members have the opportunity to actively discuss emergency scenarios in small groups. These are frequently used in public health forums, and this method helps prepare for the unexpected by building consensus through a team approach and interactive communication. These exercises allow administrators and staff members to consider their ability to manage the expected and the unexpected situations in an emergency. Tabletop exercises stimulate staff to think through the effectiveness of existing emergency and infectious disease policies, and then to, and I have this in quotes, test the policies in a mock scenario. Discussion draws out the what ifs. For example, what if there were no EMS services or hospital beds available? Or what if all the power was off for 5 days for the entire community? The discussions empower staff at all levels to find and acknowledge their abilities. Working in a long-term care facility is challenging and requires a great deal of creativity and resourcefulness. Staff members' abilities to manage problems and confront difficult issues often go unrecognized. Tabletop exercises provide an opportunity for positive feedback and reinforce those skills. Next slide, please. So This is our 6-step model, which illustrates an effective process for long-term care administrators and staff to strengthen their policies and procedures for emergency preparedness and response. The model can be used to prepare for a wide variety of critical incidences or infectious outbreaks within a facility or within the surrounding community. Some examples include local water contamination, extended power outage, outbreak of a new infectious disease such as COVID-19 or antibiotic-resistant bacteria, even things like bomb threats or others. The purpose of this exercise is to take an existing policy and apply it to an event, thereby eliciting discussions that identify strengths and weaknesses of the policy. The purpose is not to develop a myriad of new policies that fit a range of possibilities for community emergencies. Next slide, please. So this 6-step model incorporates administrator reviews of the policies, application and a walkthrough of the policies by an interdepartmental team of staff members using the tabletop exercise. Analysis of the input from the team of tabletop participants and after action report. And then any of the appropriate revisions to the policies or to their procedures. Next, an in-service training for all staff on the changes, and finally, communication of the changes to internal and external stakeholders. Next slide, please. So, step by step, the first thing that you would do is write the tabletop exercise based on the written objectives. The purpose of this is to elicit constructive discussion as participants examine and resolve problems in a time sequence scenario. Write the TTE involving either a critical incident or infectious disease outbreak relative to the selected focus area. And tailor the scenario to the facility's resident population, the staff composition, local hazards, and community resources. Design questions after each sequence that will achieve objectives. So asking kind of some of the following questions: when were the policies last updated? Do the policies designate lines of decision-making authority? What are the safety and risk considerations for staff and their families? Policies specify parameters for internal communication with the medical director, with staff, with corporate office, residents, board of trustees, and what guidelines, things even like guidelines for communicating with the media. Next slide, please. Next, you would identify the participants for the tabletop exercise. Well, and I need to go back here, but first you're going to be writing the objectives. And I think I talked about some of these, but basically the needs of the facility, the training needs of the personnel, and what the regulatory compliances might be, or just some of the things that you need to consider. Next slide, please. You will be identifying the participants for the TTE, and ideally participants of the exercise would include a facilitator, a recorder, which is actually optional, and because the facilitator could act as the recorder if needed, and 5 to 8 team members. However, if available staff is limited, it could be conducted with 5 to 6 team members. If a facilitator is not available in your facility, it could be recruited from another facility or an agency that provides similar service. The team members should be experienced employees with a good working knowledge of the facility. Next slide, please. So these would be the roles, what these folks would be expected to do as a facilitator, recorder, and team member. So the facilitator would be the one really taking charge of the activity. Facilitating the discussion, certainly making sure time constraints are met, keeping discussion on track with the objectives. And you can see what the recorder is is the person who's going to be stating the objectives and recording the entire discussion, and then preparing a discussion summary. Team members are asked to actively participate. And if we could go to the next slide, please. I'm sorry, I need you to back up. My bad. The facilitator's roles are also to establish and maintain an enthusiastic climate and a very supportive atmosphere, encourages respectful contributions from each participant, probes and encourages questions, represses personal bias and opinions, stays focused on the objectives, controls participants who try to dominate the conversation, listens actively to all contributors. The recorder takes notes of the discussion through the TTE, listens and records in an unbiased manner as well. And then, as I said, prepares the summary. And finally, the team members, and I would encourage to select individuals on the basis of their discipline or specialty area, their levels of responsibility, and their roles within the facility. Consider having representatives from different departments, things like administration, nursing, aides, maintenance, infectious controls, safety, dietary, and housekeeping. It's important to select individuals who are representatives of their peers and respected at all levels of personnel. The enthusiasm of the team members will carry over to other staff members and should secure buy-in when it comes time for staff in services. As I think I alluded to, the quality of the TTE depends largely on the participants. Therefore, recruitment of enthusiastic staff members is important. Staff members should be approached in a positive manner with acknowledgement of their skills and leadership abilities. Participation should be viewed as a perk without penalty of additional work. And really them knowing that this activity can be fun as well as rewarding. Next slide, please. The next step would be to discuss and document the tabletop exercise outcomes. You're going to discuss the outcomes in relationship to the objectives, and then address what objectives were accomplished, what may not have been accomplished and why, and then other objectives that might have been identified as a result of the TTE. Identify strengths and weaknesses, and then needed revisions, improvements, or changes to policy. Next slide, please. Step 4 is to revise policies and procedures, really developing a written action plan for implementation, which of course needs necessary approvals. Identify internal and external resources that might be needed to implement these policies and procedures. And then address additional key players who may be needed to help implement this action plan. And then it's time to assign responsibilities for the implementation. Most importantly, to establish a timeline for completion. Next slide, please. Next step, of course, is to conduct an in-service training for staff. So the tabletop exercise, replicate emergency conditions without jeopardizing the safety of residents or personnel. Trainees can learn the effects of their behavior and their responses on others, as well as gain insight into the role of others. This crossover knowledge can support daily work efforts and foster cohesiveness among members. Based on the principles of adult learning, tabletop exercises provide a valuable option for staff development. Particularly if you're creative, I highly recommend bring food, feed your attendees. It seems to be something they all really appreciate. And an important component of preparedness in long-term care facilities is to ensure that the staff and their families are prepared for an emergency. Staff development should include a discussion on personal and home planning. There is a wealth of information available on the Red Cross and FEMA websites. The changes in policies and or procedures must be communicated to all staff members so that they understand the importance of their respective roles and responsibilities in emergency preparedness and response. Next slide, please. Finally, communication with internal and external stakeholders. This last step is important because communication is a key for successful change. It's important that your preparedness plans be communicated to staff and other key stakeholders. Older people, their families, friends, neighbors, and caregivers, community, governmental, law enforcement, and public health planners, as well as officials, policymakers at state, local, and federal levels, health professionals, key members and leaders, professional organization, board members, and executive staff members, first responders, and healthcare professionals to think globally but act locally in pre-event, event, and post-event aspects of any scenario of an infectious incident or natural disaster. Next slide. And these are just some selected resources, and I'm terribly sorry my landscapers are working if you heard bad feedback.
Greetings, everybody. We find ourselves responding to a set of issues that really challenge us to function both individuals. We have to make this journey in many respects alone, but we make it in the company and collaboration of our agency partners, our own community of staff, and in our broad community. And it really represents a unique set of challenges for us. The community-based agencies really got to be nimble in this environment, and that's not always in our DNA. It requires us to act now, also not always in our DNA, to look to a longer horizon that is unknown, and the timing and character of that horizon is loaded with unknowables that we can't wrap our arms around. And finally, in the midterm, to prepare for tomorrow, literally tomorrow, the next day. So we're responding in the now, adjusting for the tomorrows, and looking to the horizon. Next slide, please. And so as an agency, we're a little bit schizophrenic. We have to think about how we honor our own mission and how our agency responds. And then also we have to look at the context with which we function as part of a broader aging network and how we function in that network. And that network also includes a requirement for community collaboration at the local, regional, and national levels. And that is also not necessarily in the DNA of every community-based organization. So Nevada Senior Services, which has a fairly wide service footprint as a community services provider, in the COVID-19 world, looked at how do we coordinate our person-centered family response, dealing with the individual and the family context in which they operate, and then how do we generate virtual activities that promote connectedness? Next slide, please. In an environment that has changed, where that face-to-face connectivity, the eyeball-to-eyeball responsiveness, maybe not available. So when we look at our coordinated person-centered family response as an agency, one of our key initiatives, Hospital to Home, is a program that was originally developed for dementia-capable care transitions to help our cognitively impaired persons, live-alones, and family-supported persons to get back out of the hospital and successfully navigate reintegration into the community. And when COVID-19 hit, one of the things that happened to that program with the support of ACL, who had sponsored the development of that program, was that we widened the lens. So we started looking at dementia capability from the perspective of people impacted directly by COVID-19, that is, they had a diagnosis. People impacted by COVID-19, they had an exposure, or people who were being discharged from hospitals or emergency departments who, by virtue of COVID-19, were isolated, and that created vulnerabilities and impacts that were unknowables for us, but that we needed to address in order to avoid rehospitalization, readmission, dangerous use of other healthcare resources. So supporting them in the community became a very significant adjustment to the way we do business. We started to move into virtual programming for our geriatric assessment programs. So all of a sudden, physicians, nurses, therapists, and social workers were providing virtual assessment, but also case management and support. Our Aging and Disability Resource Center, which was already to a great extent telephone enabled, became more virtual. And we started looking at how do we enhance community connectivity in the context in which we're living. Caregiver support, like our REACH program, became virtual. BRI care consultation demands doubled overnight. Virtual support groups doubled overnight. Telephone reassurance became the way of doing business as we had to adjust for the fact that our adult daycare person, many of whom were now at home, needed resources and supports at home. So we had simultaneously both an in-person program for a scaled down group of folks who desperately needed in-person care, and virtual for a population that was used to that in-person environment but needed to get that at home. Same thing happened to our in-home respite program. Dual response, in-home, getting our respite workers into those homes for the people who needed it and welcomed it, and remote respite support for those who were more comfortable operating at a distance. Home modifications, virtual occupational therapy assessment, but in-home installations, modified to fit the environment in which we live, and our wellness programs, including a new one, Chasing the Coronavirus Blues Away, which we'll talk about in a second. Next slide. We started creating a menu of virtual services that could cross programs. So we started the theme groups. We started looking at innovation, popcorn poetry. How can we enhance sensory activities in the home, taste, smell, hearing, and touch? Can we get popcorn delivered to their homes? Can we integrate it with an activity? Call and response poetry. Reminiscing, now integrating multiple senses. Idioms, inspirational news, so that we can enhance the mental health of our folks who are at home. Brain games to create stimulation. Doing things with products around the house, like organic clay, breathing, visualization, both for the participants and for the family caregivers. How about a morning wake-up routine? Doggy talk for those who love animals, sharing and connecting. So one of my favorites is our integration of American Sign Language for people who are hearing. Yes, people who are hearing. And it's amazing how the integration of sign language facilitates so many of the other activities. So not only is it beneficial for our hearing impaired participants, but for many of our folks who need cognitive stimulation and learning something, next slide, that requires motor planning and sequencing is just a great tool. One of my favorites has been Chasing Away the Corona Blues. Ellen Grossman, who's one of our very creative persons and leads our wellness effort, brought a sense of humor to what we know is a difficult issue of assisting people to maintain a positive attitude and to find joy in what is a very difficult situation. So we provide this program via Zoom and groups, and it is, since inception, just a week or two ago, has been incredibly popular. Next slide, please. So as an agency, we stood up, and now as a community, we stand up. So Nevada, under the banner of its governor, adopted what we call Nevada CAN, which is a collaboration of the entire aging network. Next slide, please. And it really focused on marshaling all our resources statewide to respond and create collaboration among our aging services providers under the leadership of our Nevada Aging and Disability Services Division, and its very capable administrator, Dina Schmidt, who chairs this effort. And as you can see, the intent was to bring together government, community-based organizations, clinical providers, including telemedicine, primary care, telesocial work, and the university system into an integrated response. Next slide, please. To our most vulnerable, by mobilizing all these resources and generating access around the state in a collaboration and in a way that would facilitate the ease of people who wanted to get engaged because they needed services or wanted to get engaged because they wanted to volunteer and find a way to mitigate the impact of COVID-19. Next slide. And so you can see these are some of the touchstone areas and the way we communicate through an integrated website, the Nevada CAN site, which we'll look at again in a moment. But isolation, grocery delivers, essentials, medications, access to healthcare, and trying to find easy push button ways through instant communication to provide warm handoffs to services. Next slide. That people could reach or be supported in their reach. So the objectives of Nevada CAN statewide were to provide credible information and resource availability, to utilize students and volunteers to provide elder connectivity, to make sure that essential services, food, medication, pet food, medical supplies were reaching those most vulnerable, that our county service agencies and not-for-profits were supported with volunteers to help with things like home delivery of essential items, and that we could marshal telehealth to reach people in their homes. Next slide, please. So our major activities were to mobilize a statewide media campaign, to launch and maintain an integrated agency website with information and referral, access to program resources, connectivity for essential daily needs, virtual social support, and telehealth. Next slide, please. And so the website we stood up, which is integrated with our 211 system, is designed to facilitate that in 1 or 2 clicks. So this is our entry point into the system. You'll notice 211 up at the top. Next slide, please. And then easy buttons. Next slide, please. And so telephone numbers and email addresses and access points throughout the state. Next slide, please. Easily accessible to folks, and one button push to areas of concern. So the Nevada Care Connection, reporting elder abuse, dealing with social isolation, shopping assistance. Next slide, please. A vehicle for how help can be requested. Next slide, please. And simple checklists so that people can check a box and then get a referral and a warm response. Next response. Next slide, please. And that's the key. How do we make it easy? How do we make it simple? And how do we integrate as a community-based services agency from ourselves to our colleagues to our broader community? And how do we make the local and state situation better while we're still addressing as an agency, honoring our mission and adapting our services to meet the needs of this very challenging environment? And with that, I'm happy to turn over presentation to Kathy Heyer to talk about recovery.
Hello, thank you. Good day to everyone. I'm delighted to be here, and I want to thank our wonderful government colleagues who have organized this important and interesting session. I'm pleased to have this opportunity to share the work on the effect of hurricanes on the well-being of residents of nursing homes and assisted living. Understanding the effect of hurricanes on residents of nursing homes and assisted living communities began in 2004 when 4 hurricanes, including 2 major hurricanes, crisscrossed Florida in 44 days. Since that time, I've worked to understand why mortality is underreported, why nursing homes do not have the priority that I believe they should within emergency management systems, and what the consequences of hurricanes mean for frail older adults. Because I have 13 minutes to share almost 16 years of findings, my presentation will not include all the methodological details you'd normally hear, but I've included a list of our publications at the end of the presentation, as well as a few resources. If you have questions, please contact me or any of the colleagues. Next slide. Next slide, please. Yes, this slide shows the people who have been working with me for years, and our prior work. Thank you. Any of these people who are PhD students at Brown and at USF, as well as my dear colleagues, will be happy to answer questions. Our next slide. Our initial work focused on hurricanes Katrina, Rita, Gustav, and Ike. We received also money from the Hartford Foundation for qualitative interviews and training materials to improve the status of nursing homes. Our earlier work indicates that 1, mortality as a result of being in the path of a hurricane is underreported. CDC and states count bodies that have deaths during and immediately following the hurricane. Our method, which I'll explain shortly, calculates hospitalizations and mortality for the 30 and 90 days after the storm. 2, recognizing that this webinar is highlighting the special needs of residents with Alzheimer's disease and related dementias, I'm highlighting the study led by Lisa Brown that calculates the added risk of mortality for those who are most cognitively impaired. And 3rd, Callie Thomas worked to establish that hospitalizations increased, not mortality, for the most functionally impaired residents. Next slide. Hurricane Irma was a Category 3 massive storm. The entire state was in the path. It landed in the Keys and then landed again in Naples, Florida on Sunday afternoon, September 10th, 2017. Next slide, please. Our methodology to calculate these morbidity and hospitalization rates is as follows. First, we create the geographic path of the storm. Second, we identify all nursing homes and assisted livings in that path. Third, we determine which residents were in those nursing homes and assisted livings as of a certain date, in this case, September 1. Fourth, we use the most recent resident assessment and link that assessment at the individual level to hospitalizations and mortality and other records that we have access to. And fifth, we identify all the nursing home residents in those same nursing homes 2 years prior to create a comparable group of residents, or control group, as it were. Next slide, please. This slide notes the incident rates and the odds ratios of first hospitalization and mortality in residents exposed to Hurricane Irma compared to that control group in 2015. Within 30 days, the odds of a first hospitalization were 1.12 among those exposed and 1.07 at 90 days. The odds of mortality were 1.13, 13% at 30 days, and 1.07 at 90 days. All these odd ratios are significant. And this is consistent with our earlier work looking at the total effect of the storm on the residents who are in the buildings in the path of the storm, what we call the exposure. Next slide, please. Our current work has advanced our initial findings because we are now looking at both the short stay and the long stay residents. Short stay in nursing homes are 29 days prior to the hurricane, and the long stay are there for over 2.5 years. We still see the increased overall hospitalization for both groups, and this is significant for both groups at the 30 and 90-day rates for first hospitalizations. We divide those who are they're the ones that will have increased mortality at both 30 and 90 days. These are the residents who are most at risk. Next slide, please. All hurricanes wreak destruction, havoc, chaos. Irma's winds resulted in widespread and sustained electrical outages. This map shows the path and the sustained effect of these hurricane outages. 6 million homes and businesses lost power at the height of the storm. All those dark areas on the left are areas where power was out. And even on the areas on the right, 3 days later, you'll see substantial numbers of places without power. There were large numbers of nursing homes without power for over a week. That's why, as Dr. Samir pointed out, Florida became the first state to require all nursing homes and assisted living to have alternative power sources. I'm raising the electric power outage because this is where our qualitative data may have some insights into the effect of the storm on recovery. While hurricanes are only one type of disaster, the time to restore things to what people call normal varies. And it's based on the physical damage, electrical restoration, water restoration, internet resources, all the things we take for granted when things are normal. Next slide, please. Again, I don't have time to describe our methods in detail, but we recruited assisted livings and nursing homes in the path of the storm. We hope that discussing and talking to you about the time to recovery after a hurricane, while not quite the chronic disaster we're all experiencing with COVID-19, will help us begin to provide some insights that we'll find useful and helpful as we all navigate these waters. The work that we have done is based on, or the quotes I'm going to show in the qualitative data, is based on 95 interviews with both assisted living and nursing home providers. Next slide. Based on our qualitative interviews, we suggest that there are 4 areas that are important as we think about recovery. I'm naming them here and we'll discuss them in more detail in the slides that highlight each theme. First, the challenge of how to communicate with families. Second, the effect of the disaster on residents with dementia, which we repeatedly heard was exhaustion and increased disorientation. Third, the effect of the hurricane on staff, which again is exhaustion, sometimes PTSD, and many times, unfortunately, leaving the industry. And finally, the nursing home and assisted living's ability to receive help from emergency management offices at the state and local level. Next slide, please. For long-distance caregivers, it was stressful and challenging to know what was going on. This should be heart-achingly familiar to all of us. Administrators discussed ways to keep families involved, especially long-distant caregivers. As this assisted living administrator from a large AL indicated, some of the caregivers would actually take snapshots and they would put them on Facebook just to let family members know. They take little videos, and we sent those. We did have a couple of people that were able to Skype, so that was a way to get a better idea, meaning how well the residents were doing. Next slide. As most of us realize, constant messages of fear from TV or news is distressing. The advice, turn off the TV and figure out other activities to do. Next slide, please. Our earlier work and our current interviews with nursing home and assisted living administrators suggest that there's trauma from the nursing home residents' experience, from the anxiety of the disaster, from the disruptions to their schedule, from the fear that many staff who were with them are also experiencing, and that the effect of remaining for a considerable amount of time continues. This is our recovery period. As the first quote indicates, my memory care folks particularly were very agitated for a week after returning to the facility. The interviews reinforced themes of declining cognition, confusion, and ongoing stress. A recommendation we heard from many is captured in this second quote: having a routine, and that routine filled with activities that keep them engaged, is beyond important. Next slide, please. We continuously heard that the disaster required a lot of hands-on help and attention to residents. Staff, all staff, worked very hard, and as this first quote indicates, the time after the storm was when the real work started. We had to make extra efforts to keep residents safe. This was because despite the passing of the storm, work was not normal. There was ongoing concerns because despite the immediate hurricane passing, a great deal of work needed to be done. There was physical problems with plants, and we already talked about the issues of electricity. This is the recovery period that I'm talking about. And because about 2/3 of the budget of nursing homes is paid to direct care workers, this quote summarizes the extraordinary work of these direct care workers. There needs to be, any way you can write this up, the fact that some of the lowest paid personnel are the ones who work the hardest. Everyone works hard, but they poured their guts out. Next slide, please. And as I alluded to from the beginning, despite real improvements, at least in Florida, with emergency management offices working with many nursing homes and assisted livings, nursing homes struggle to get the attention of the very offices that deploy the resources at the state and local level, especially as we deal with COVID-19. The quotes here about emergency management that I kept expressing that we're a nursing facility, and the bottom line was, I don't think they cared. That's really troubling. Next slide, please. Our work suggests training does help. 2 programs, both in the public domain, may be useful to nursing home staff who would benefit from training on managing adverse health, mental health effects of disasters on residents. Psychological first aid is a technique that can be used by staff, not just licensed clinical practitioners. The Pleasant Event Scale helps create resident-centered pleasant events. This is a checklist that can be used to identify pleasant and positive aspects of life, things that will bring residents pleasure. Next slide, please. To summarize, mortality is beyond an initial body count. Our current work indicates and is sustaining over time, mortality in nursing home populations is significantly and continuously underreported. Secondly, nursing homes remain a lower priority in emergency operations centers, despite lots of us trying to change that. Third, the consequence of not prioritizing nursing home residents is a worsening of cognitive and functional decline. And obviously, that's very troubling. Next slide, please. Lest anyone feel that they can rest on their laurels, I put this slide in to remind all of us that even in this chronic disaster period of COVID-19, other disasters can and will occur. Hurricane season begins June 1, but there's already a storm lurking out in the Bahamas. Thank you again for your attention and your commitment to older adults, especially to those with cognitive impairment. The next 3 slides can be gone through quickly. They're basically the resources and references. And the next speaker.
All right, thank you, Kathy. Good morning or good afternoon, depending on which time zone you're in. My name is Nia Reed, and I am the older adult subject matter expert helping with CDC's emergency response of the 2019 novel coronavirus. I'll be giving a brief overview on the work that CDC has done and the ongoing work happening for the COVID-19 pandemic emergency response regarding older adults. Next slide. First, what is COVID-19? COVID-19 is caused by a coronavirus called SARS-CoV-2. Coronaviruses are a large family of viruses that are common in people and may be found in different species of animals, including camels, cattle, cats, and bats. Rarely, animal coronaviruses can infect people and then spread between people. Next slide. COVID-19 may be present without any symptoms, or symptoms can range from mild, such as a cough, to severe illness, such as cardiac arrest. Next slide, please. Other symptoms of COVID-19 can include some or all of the following: cough, shortness of breath or difficulty breathing, fever, chills, repeated shaking with chills, muscle pain, headache, sore throat, or new loss of taste or smell. Next slide. The virus is spreading easily and sustainably from person to person, and you can become infected from respiratory droplets. When an infected person coughs or talks, droplets can enter the mouth or nose. By touching a surface or object that has the virus on it, and then by touching your mouth, nose, or eyes, droplets can be inhaled into the lungs as well. Or by coming into close contact, that's about 6 feet or 2 arms length, with a person who has COVID-19. Next slide. Older adults and people of any age with severe underlying medical conditions are at higher risk for developing more serious complications from COVID-19. However, 8 out of 10 deaths in the U.S. have been in older adults age 65 and older. Older adults are also at increased risk of stress and anxiety associated with COVID-19. Because of the increased risk, CDC is advising older adults to stay away from the general public or to shelter in place as states reopen. CDC is also advising long-term care facilities to restrict visitors. This can lead to social isolation and depression. Particularly, depression from social isolation is a concern for older adults because it can and has often been mistaken for a normal part of aging or be interpreted as a cognitive issue. Next slide. The U.S. Bureau of Labor Statistics report that Americans aged 65 and older have nearly a 36% participation rate in the workforce, and if there is no telework allowed, older adults must report to work. If you have to report to work, CDC recommends to practice social distancing, wear a cloth face covering over your nose and mouth, clean and disinfect your workstation, wash your hands frequently, get screened if screening is available, and if you're sick, to follow CDC guidance on how to take care of yourself. Next slide, please. And because dementia primarily affects older adults, and older adults have a higher risk for severe illness associated with COVID-19, it is important to note that for people living with dementia, changes in behavior or worsening symptoms of dementia should be evaluated. These changes can possibly be an indication of COVID-19 or other infection, and they include increased agitation, increased confusion, or sudden sadness. Next slide, please. At the moment, there are currently 2 projects focused on older adults that are funded by the CDC Foundation. The first is the NORC projects, which targets people age 65 and older and their caregivers, people with pre-existing medical conditions, people experiencing violence, including suicide, intimate partner violence, and elder abuse, and finally, economically disadvantaged individuals. This project aims to develop, implement, and evaluate public health messages and materials to promote stress management, mental health, and resilience during the COVID-19 response and recovery efforts. The second project is the Innovative Technologies Project, which targets older adults only. This project aims to broaden and build social and emotional support systems and resources to address the negative effects of social isolation and stress among older adults and their caregivers. Some of the activities will include disseminating technology hardware like iPads or notebooks, promoting telehealth services, and building a volunteer platform. Next slide, please. CDC releases content regularly, including the ones you see here. So as we learn more about risk factors for COVID-19, please check out our website. Our website is www.cdc.gov/coronavirus/2019-NCOV. Next slide, please. CDC also has great informational resources associated with older adults, including guidance, articles, videos for the COVID-19 emergency response and recovery, which can all be found on our website or by clicking on any of these links. Next slide, please. For more information, please contact CDC at 1-800-CDC-INFO. That's 1-800-232-4636. Our teletypewriter communications can be reached at 1-888-232-6348 or at www.cdc.gov. Thank you, and now I'll turn it back over to our moderator.
Good afternoon. This is Joan Weiss from the Health Resources and Services Administration. On this slide, we provided you with some emergency preparedness resources from the American Public Health Association, the Centers for Disease Control and Prevention, the National Alzheimer's and Dementia Resource Center, and the National Institute on Aging. The links are live, so when you receive the slide presentation, you'll just be able to click on the link and it'll take you to that resource. Next slide, please. So if you like our presentation today, we have more to come, and just some brief information about the Focus on Aging Federal Partners webinar series. This webinar series addresses important topics for public health and healthcare professionals, aging services organizations, the research community, and other stakeholders in aging. The series is a joint project of 4 federal agencies that support the health and wellness of older adults in the United States, including the Administration for Community Living, the Centers for Disease Control and Prevention, the National Institute on Aging, and the Health Resources and Services Administration. Each webinar will include information specific to individuals with Alzheimer's disease and other types of dementia, as well as their caregivers. So our next webinars are as follows. In September, we're going to be talking about social isolation and loneliness. January 2021, workforce to support the needs of older adults. And in the spring of 2021, disclosure of research and clinical findings related to cognition. And there's a link to the webinar series at the bottom of the slide. Next slide, please. And with that, I would like to thank all of our outstanding speakers and also all our attendees for taking the time to join us today. Now I'd like to turn over the session to Grayson Donnelly, who will be running the question and answer session.
Thank you, Joan, and thank you to all of the attendees who submitted questions or comments. As a reminder, if you still want to send a question, you can do so using the live feedback form if you scroll down to the bottom of the video cast. A couple of you asked questions regarding whether or not you will receive the slides. Yes, you will receive the slides as well as a link to the recording of this video cast. We received another question. I think this is for Lisa McGuire. Where will there be a CEU for this webcast?
Thank you, Grace. And unfortunately, there will not be a CEU option available for this webcast.
Thank you. And we received another question. This is directed to Jeffrey Klein. The question is, I'm wondering how you were able to make sure that everyone had internet or access to the at-home services.
Great question. Thank you. The answer is in our urban areas, we managed to find ways to provide access to people. In our rurals and frontier areas, it's much more difficult, and we are not always successful in doing that. And so we have to rely on telephone-based technologies in those communities to link people. And it's quite a challenge in Nevada, where we have a great deal of frontier individuals where we don't have either direct internet or even in some instances satellite internet. So it is a challenge. We try to use as I mentioned, the telephone lines as much as we can, particularly for telephone reassurance and information services. In some instances, we're actually able to get equipment to people, but only if they're in parts of the state that have connectivity.
Thank you. And another question just came in. I'm not sure which presenter will be able to answer, but the question is, how can older adults access more than 30 days of medications? Don't most insurance companies only fill for 30 days?
This is Jeff. A lot of plans you can request a 90-day or even longer medication delivery. And we are recommending as much as possible that seniors make that special request. To our knowledge, most of the plans are honoring those kinds of requests, both in terms of shipments to home and also through local area pharmacies. There are some plans that will even allow some longer distributions, but we have routinely suggested make the 90-day request, and we've been reasonably successful in having those things approved.
And it's Dr. Sinha here. I think one of the things when we looked at this was that the only state that we could find in our policy review was actually Florida, that actually has implemented an emergency order so that if you know a hurricane is coming, then you can actually go to your local pharmacy and get a 30-day supply, even if your supply isn't up. The challenge we heard from across the country was that within the US, if you're not necessarily out of your supply, if you're still currently within a prescription, you may not be authorized for renewal. And so there's an opportunity there for us to think about how we can close that gap, if you will.
Thank you. And I believe this question is for Mia Reed. Is there any information regarding neurocognitive disorder by itself increasing the risk for COVID-19 poor prognosis, or increasing the risk for getting it other than the fact that they may forget to wash their hands?
Thank you for that question. There's nothing out right now about that, but we're still learning about the virus. And so if you have questions that I can't answer for you here today, feel free. We have a ton of incredible experts who are at the Emergency Operations Center who can help with these questions. But feel free to email at the email address that's on my slides or call the 1-800-CDC info number, and they should be able to get back to you with a definite answer.
It's just Dr. Sinha here as well, is that, as was being said, there is no evidence to suggest that, but there is concern that when a person who has dementia, as was mentioned, they may forget to wash their hands. Also, those who wander, who are living in, say, nursing homes, and may easily walk around and be in contact with others. That's where we're seeing the greater risk for people with dementia, when they may not remember to physically distance appropriately as well.
Thank you. And I will let the panelists decide who is most appropriate to answer this next question. Is there anyone you are aware of working on making sure that people who use powered mobility can be evacuated with their equipment and their caregiver in emergencies?
Dr. Sinha here. So I can tell you right now that the American Red Cross is actually working on a power outage resource. I think this has been funded by one of the federal agencies so that we can better support people who are dependent on power in a whole variety of circumstances. Right now, what we did find in our Closing the Gaps review was that there are sometimes utility companies that you can let them know you actually are power dependent, so they can give you appropriate advice. And sometimes there are what we call vulnerable persons registries at a community level, where you can register based on that issue or others, so that you may be a candidate for priority service. But I think someone else may be able to answer further.
This is Kathy Heyer. My experience would be the same as yours. There are special registry lists that can possibly help you. There is also a Medicare database, right, in Power, that helps identify people who need power. But I think that's done both through the registries and also through the power companies.
Thank you. And the questions are still rolling in. I'm going to remind everyone that we will compile all of the questions that we're not able to answer live and try our best to email you a response to your question. Let me look back now. I believe this is a follow-up for Jeffrey Klein. Do you have suggestions for bringing programs to those persons who are not technologically savvy?
The tech savvy issue is really a problem, particularly in our aging population. And what we've attempted to do, and we've been using some other resources to do it, is to get people, I hate to say, use the term, but pencil and paper technologies to get it to their homes. We have people dropping off those technologies with food deliveries and bags, mixing it up with other kinds of deliveries, including medications. And if necessary, we'll just send somebody out to someone's home. And so that we'll create pencil and paper programs and activities that then can be activated by talking to somebody in a telephone reassurance mode. And it seems to work reasonably well, particularly if there are family members around, so you can turn it into a community activity. And also using our conference calling capabilities. So again, we try to get them some material and get it to them in advance, and then use the telephone as best we can. Interestingly enough, one other thing that we've started to play with a little bit is using commercially available television. If people have the ability to record, which a lot of folks do, and then pulling an activity out of something that's on commercial TV and turning it into an activity.
Thank you. And I think this next question might be our last question, and it's for all panelists. What community partners have been helpful in assisting with the needs of older adults, especially in providing accurate information?
Hi, this is Nia Reed. I can just speak to what's been happening for the COVID-19 response. We have really had a lot of great talks and conversations and help from ACL, from AARP, from Alzheimer's Association, from all the people, all the organizations that are here on this panel. We've had really a lot of great input and expertise to help with this emergency response related to COVID-19.
This is Margie Sanders, and our health departments have also been great partners for us.
I was just going to say, public health has really changed, particularly with COVID-19. They're doing an incredible job here in Florida too.
This is Jeff. Our state unit, our state aging unit, has been amazing. Standing up resources, providing connectivity, being a convener and a collaborator, and also a special tip of the hat to ACL. It's great to hear Erin's voice on because she's actually convened groups of us, which have allowed for interchange in areas like geriatric assessment and adult day care. And that's been particularly helpful, not only in terms of information exchange, but dealing with the loneliness factor that those of us on the front lines sometimes feel disconnected from our colleagues. So both been great resources for us.
And this is Kathy again. The Alzheimer's Association has been also very good at trying to create more resources, and they're doing a lot of work here in Florida with tablets and ways to decrease loneliness, along with our state unit on aging, the Department of Elder Affairs.
Thank you. And looking at the time, I think we actually have one more question we can bring to the panelists. Again, for all panelists, can someone comment on specific interventions to support diverse populations?
Dr. Sinha here. I think certainly one of the things that we are seeing when it comes to disaster preparedness or even pandemics like COVID is that we find that diverse and more marginalized populations can be more at risk. And sometimes it's because the materials that we're presenting are largely in English or our main languages. And sometimes people may have challenges connecting with information because they may have a lack of internet access or other resources that way. And so if one is working with a community, we often recommend through the Red Cross and others that people try and understand how best to share credible information, find out what the gaps may be in terms of access to certain types of resources to respond, and figure out the best way to share information and resources to keep people healthy and well. So that's just some of the starting points that I would say.
Thank you. This is Nia Reed. Regarding the COVID-19 response, CDC has been very deliberate in making sure that our funded projects focus on and are very inclusive of different populations, especially more vulnerable populations, on top of being 65 or older, racial and ethnic minorities, as well as people who are experiencing violence. So we are being very deliberate in making sure that we fund projects or that we are part of projects that are that have that outreach.
Thank you all. And as a reminder to any attendees, if you still have a lingering question, you can use the live feedback form, and we will do our best to email you a response if we were unable to answer it live. And with that, I will turn it over to Lisa McGuire.
Well, thank you very much for attending the first 2020 Focus on Aging Federal Partners webinar series. As part of the planning committee, I want to share our great appreciation to our colleagues at the National Institute on Aging for their technological sophistication in providing the platform for us today, mainly Elizabeth Prickett, Grayson Donnelly, and Nina Silverberg. As we've mentioned, in a few days, you will receive an email with a link to the recording and the slides, as well as other resource materials. So once again, thank you very much for your attendance and participation today.